So hi guys, good afternoon. Today we're going to talk about non-contact low-frequency ultrasound therapy compared with UK standard of care for venous leg ulcers, a single-center assessor-blinded randomized controlled trial by White et al. So this is presented to you by Kirk Alcoba, yours truly, Unisgo, and RJ Resentes. So there will be four major contents of our presentation, which are the introduction, methods, results, and discussion. So first, introduction. So vascular ulcers, venous and arterial ulcers, diabetic ulcers, pressure ulcers are classified as chronic wounds. The scale of the problem of these wounds is huge and well documented. Chronic wounds display characteristics such as prolonged inflammatory phase, persistent infections, formation of microbial biofilms, and ineffective dermal and epidermal cell response, which differentiate them from acute wounds. However, if appropriate standard of care, or in short SOC, is initiated in a timely manner, such as chronic wounds can often follow a normal healing trajectory. Troxler et al. Introduces the term hard to heal, which better explains a wound which fails to heal with standard therapy in an orderly and timely manner. Decades of research has led to a greater understanding of the complex pathophysiology of chronic wounds, raising many further questions in the process. So, chronic leg ulceration prevalence in the UK is estimated to be 1%, with between 0.12% and 0.32% of the population having an open ulcer. Venous leg ulcers, or VLUs for short, become more common with age, and many patients suffer from the condition for a number of years. Patients with VLUs have a substantially poorer quality of life, which is often because of the pain, odor, recurrent wound infection, and reduced mobility associated with chronic leg ulceration. The cost for treating unhealed venous ulceration in 2005 to 2006 to the NHS was at least 168 million euros per year. So, Tenval and Jamgen 2005 showed that the average total cost per patient for treating a VLU for 52 weeks in the UK ranged from 1,121 euros to 2,142 euros, depending on the size and duration of the wound. So, the MIST therapy system is a low-intensity NLFU device designed to promote the healing of chronic wounds. The device delivers continuous ultrasound energy at 40 kilohertz frequency through a fine saline mist to the wound bed. And it is claimed that sound waves stimulate the cells within and below the wound bed to promote wound healing through down regulation of inflammation, a reduction in the number of bacteria, and an increase in blood flow. So in the year 2011, the National Institute for Health and Care Excellence issued medical technologies guidance, which stated that NLFU shows potential to enhance the healing of chronic, hard to heal complex wounds compared with standard methods of wound management. The NICE committee noted that the quality of the evidence was limited by small patient numbers and lack of appropriate comparison groups. NICE's published guidance recommended comparative research in the UK to reduce uncertainty about the outcomes of patients with chronic wounds treated with NLFU therapy compared with those given only with standard care. So at the time of this study, randomized controlled trials had been carried out in patients with ischemic limbs and patients with diabetic foot ulcers, treated with using non-contact low-frequency ultrasound therapy. Since then, a study on patients with VLUs has been published at a pilot study. These randomized controlled trials and several retrospective observational studies have reported that treatment with NLFU improves wound healing. So, Cavros reported that significantly more patients with ischemic wounds treated with NLFU achieved 50% wound closure at 12 weeks compared with those of standard of care rate alone. Ennis et al. Reported no significant difference in the number of diabetic foot ulcers healed after 12 weeks of NLFU or standard of care by intention to treat analysis, but a significant difference from per protocol analysis. Extrapolating the results from Ennis et al. Into a US-based cost model revealed savings of 19.5% from NLFU compared with standard of care. So this study is an integral part of NICE's medical technologies evaluation activities to facilitate the development of further evidence stemming from recommendations in published guidance, coupled with the fact that there is limited high-quality evidence on patients with venous leg ulcers treated with NLFU. This study has been designed to answer a specific research question posed by NICE. What is the utility of NLFU as per the manufacturer's instructions for use in the UK healthcare system compared with the standard care for venous leg ulcers? And therefore, this is going to take us to the objective of the study, in which, coupled with the fact that there is limited high-quality evidence on patients with VLUs treated with NLFU, this study has been designed to answer a specific research question posed by NICE. What is the utility of non-contact low-frequency ultrasound in the UK healthcare system compared with standard care for venous leg ulcers? So this is our objective. This is the study's objective. So the primary objective, based on the outcome measures defined in the Medical Technologies Guidance Scope, was to test whether there would be a difference in the change in wound area of chronic venous leg ulcers treated for 8 weeks with non-contact low-frequency ultrasound plus standard of care compared with standard of care alone. So now let's move on to the patient selection. So, adults with chronic venous leg ulcers that is not less than 6 weeks and not more than 5-year durations, and between 5 and 100 centimeters squared area at randomization, and an ankle brachial pressure index or ABPI of greater than 0.8 were eligible to participate. All 36 randomized patients completed the treatment. So 17 participants were for the NLFU plus standard of care, and then 19 were for the standard of care alone. And baseline demographics were comparable between the groups. So basically, there were 100 during the screening visits conducted, and then 47 during the patients who were enrolled in the study, and then 36 remained during the randomization. So what are the criteria that were followed in selecting the patients? So exclusion criteria were as follows. So uncontrolled diabetes, index ulcer has active infection during the day of inclusion, requiring systemic antibiotic therapy, renal failure, exposed tendon, ligament, or muscle or bone in the index ulcer, osteomyelitis, cellulitis, or gangrene in the study limb, subjects with an amputation above transmetatarsal in study limb, active malignancy affecting the study limb, index ulcer is of arterial etiology, pregnant or breastfeeding women or women of childbearing potential not willing to use a method of high effective contraception for the duration of the study. What else? Planned vascular surgery, angioplasty, or thrombolysis procedures during the study period. Planned surgical procedures during the study period for the index wound, prior skin replacement, negative pressure therapy, and ultrasound therapy to the study wound in the 2 weeks before screening. Currently, receiving or has received radio or chemotherapy within 3 months of randomization. Index wound would require ultrasound near an electronic implant or prosthesis, not capable of providing informed consent, and currently enrolled in or has been enrolled in another investigation device or drug trial in the last 30 days. So, as I said, the acceptable criterion were adults with chronic venous ulcers and the appropriate ankle brachial pressure index, and then patients whose wounds reduced by greater than 40% during the first 4 weeks, run in phase where standard of care only was administered, were withdrawn, and did not progress to randomization. In this run-in phase, selected for wounds which were hard to heal, and also standardized the care provided to patients as they had been recruited from a variety of settings. Standard of care for the patient of venous leg ulcers were compression therapy with a low adherent dressing in contact with the wound in accordance with the NICE pathway for treatment of a patient with a venous leg ulcer. So now let's move on to the methods, which will be reported by RJ.
Yes, Yun, thank you. So now for the methods that the researchers used for the study. So first off, we have the study design. The study was a UK-based, single-center, assessor-blinded, randomized, controlled trial designed to show superiority. No substantial amendments were made to the trial protocol after the commencement of the study. So for the study procedures took place in a single dedicated unit specializing in wound healing research between August 2012 and November 2013. All enrolled patients received 4 weeks of SOC or standard of care prior to random allocation. So below you can see a study design flow diagram. So it compromises of the NLFU or the non-contact low frequency ultrasound, SOC, the standard of care. So compression therapy and dressing change at least once a week, wound assessments weekly, ultrasound therapy with compression and dressing change at least 3 times a week, with wounds assessment weekly. So the SOC comprise clinic visits once a week in which the wound was bathed, sharp debridement was performed if necessary, and non-adherent dressing was applied with compression delivering 40 to 60 millimeters of mercury at the ankle. More frequent visits were arranged if deemed clinically necessary. For example, owing to a highly exudating wound or evidence of infections. Following random allocation, patients either continued with SOC for 8 further weeks or received NLFU therapy combined with SOC. So the NLFU consisted of the application of the missed ultrasound therapy to a clean wound bed for between 3 and 12 minutes, at least 3 times a week. So a non-adherent dressing and strong compression therapy was applied after the NLFU application for 3 times a week. Now for the study assessments, wounds were assessed once a week for 12 weeks. So and a final visit on the week 13. The assessments comprised of a wound measurement using a Silhouette Star digital imaging device. Pain scoring with the use of visual analog score from 0 to 100, and condition wound bed and peri-ulcer skin. Digital photography and presence of malodor. Wound margins were traced on the imaging device by a single blinded assessor to obtain area measurements during the treatment phase. The nature and the frequency of all the adverse events were recorded. So, next slide. So, on the first and final visits, participants were invited to complete a Cardiff Wound Impact Schedule or a CWIS, which is a validated questionnaire designed to measure the impact of chronic wounds on patient health-related quality of life. So the questionnaire consists of the three domains. One being the physical symptoms and daily living, the second being the social life, third being the overall well-being. So it is transformed to a score between 0 to 100 for each domain. The patient also gives a global health related quality of life score and satisfaction with the HRQOL, each between 0 and 10. Okay, and now moving on to the outcome measures. So for the the outcome measures, the primary outcome was the change in the wound area from the baseline week 5 to 13 or to the point of healing in order to control for the baseline wound area and measurement as determined by weekly digital wound measurements with blinded assessment of wound margin. Secondary outcomes were changed in HRQOL from enrollment to week 13 or point of healing. Incidence of clinical infection, pain scoring, and wound characteristics like the wound's odor, exudate, and wound bend characteristics. The proportion of healed wounds that closed 90 days later was recorded. Next off, this part will be reported by Kirk Alcoba.
Thank you, RJ. So the sample size calculations. So the study was powered to detect a difference in the change in wound area of 20% between the two arms with a two-sided significance level and power of 90%. A standard deviation of 17.5% came from published literature, so a minimum of 17 patients in each arms was required, and with an anticipated withdrawal rate of 15%, our aim was to recruit 40 patients or enough participants to meet the sample size. Higher than anticipated withdrawal rates prior to random allocation meant that a total of 47 patients were recruited to reach the minimum number of patients in each arm of the study as determined by the power calculation. So next is the randomized allocation and assessor blinding. So following the 4-week run-in phase, the patients were allocated to standard of care or non-contact low frequency ultrasound therapy plus standard of care using an off-site telephone service where staff had no clinical involvement in the trial and were not involved in the recruitment progress. Patients were assigned using a minimization program to minimize the imbalance on two prognostic factors between the two arms of the trial. Both factors were unweighted and had two categories. Group 1 has greater less than and equal to 5 and greater than and equal to 10 centimeters squared. Group 1 has less than or equal to 6 weeks, and is greater than 12 months, while group 2 has less than 10 and greater than or equal to 100 centimeters squared, and 12 months, uh, less than or equal to 12 months, and greater than or equal to 5 years. So to reduce the possibility of selection bias, minim was minim is not entirely deterministic, but is approximately 70% to the preferred allocation. To further reduce the risk of allocation prediction, the investigators were blind to the cutoff values for each category, and the allocations was only provided once the patient details has been irreversibly entered into Minim. So patient and clinicians providing care were aware of the treatment allocation. A single primary outcome assessor bind to treat allocation trace the wound boundary of each weekly wound measurement using the silhouette star system. So next, the statistical analysis. So all randomized patients were included in the intention to treat population. Continuous data were checked for normality using Kolmogorov, Smirnov, Z-score for skewness and kurtosis. Visual inspection of box plots and histograms, standard of care and NLFU plus SOC data were also checked for homogeneity of variance using the Levene's test, where data were normally distributed. The mean was standard with the mean with the standard deviation was reported. Where data deviated from normality, medians were reported with interquartile range. So ANCOVA was used to analyze differences between the NLFU and plus standard of care and standard of care only arms of the patient of the primary endpoint. Percentage change in wound area from the baseline, which is week 5, to the final visit, which is the 13th week. So the patient's baseline, which is week 5, wound area was used as the covariate. Differences between the groups in actual change in the wound area or the centimeter squared between week 5 and week 13 were also analyzed in this way. Differences in the primary outcome between groups were also analyzed using the students' t-test and reported as non-adjusted data. So ANCOVA was also used for the secondary outcome change in HRQOL from weeks 1 to weeks 13. So with week 1 HRQL QOL score as the covariate and the change in pain score or the VAPS from week 5 to 13. All variables were checked to ensure that data did not violate the assumption of normality, linearity, homogeneity of variances, and homogeneity of regression slopes. So the changes in quality of lifestyle scores and the number of infections were not normally distributed, and differences between the arms were tested using the non-parametric Mann-Whitney U test. Differences in the number of patients have at least one AE were analyzed using Fisher's exact test. In all tests, p-values less than zero point 0.5 were considered to be significant and the tests were two-sided. No correction was applied to account for the increased probability of a type 1 error associated with the multiple testing because no p-values were detected to be less than 0.05. So now, the results. So primary outcome, so the patient treated with NLFU plus SOC for 8 weeks showed a negative 46.6 standard deviation of 38.1 mean change in the wound area, while the patients with standard of care only for 8 weeks showed a negative 39.2% of mean change. So patient in both arms showed a reduction in the wound area during 12 weeks of the trial. And a left view plus SOC wound showed a mean reduction of negative 48.7% and a median reduction of negative 60.32 during the week 12. So standard care patients showed a mean reduction of 40.15% and a median of 38.6% during week 12 of the study. So as you can see on the left, there's a table there where the mean change in wound area is tabulated. from week 5 to week 13. So next is um, the patients healed during the study period. One NLFU plus SOC patient healed after 7 weeks, and one after 8 weeks of NLFU plus SOC treatment, and one patient who received standard care alone healed after 4 weeks. All three of these patients remained healed 90 days after the end of their study treatment. 9 wounds in the NLFU plus SOC arms, which is 52.9%, and 7 wounds in the SOC arm, which is 36.8%, reached at least 50% closure after 8 weeks of treatment, but it's still not a significant difference. So 12 NLFU plus SOC wounds, which is 70.6%, and 10 SOC wounds, which is 52.6%, reached 25% wound closure. So 2 patients each in both arms did not improve during the course of the study. Next, the second outcomes, which is the incidence of adverse effects and infections. So a total of 60 adverse effects, 24 in NLFU plus SOC arms, and 36 in SOC arms alone were recorded as infections of the index ulcer or peri-ulcer skin during the course of the study. No significant difference was observed in the median number of infections per patient between the NLFU plus SOC and SOC arms alone. Next is the health-related quality of life. So NLFU plus SOC and SOC patients showed a modest improvement in domains of well-being and physical symptoms and daily living of CWIS questionnaire between enrollment and the study end. In the domain of social life, and NLFU plus SOC patients reported an improvement of 3.0, while SOC patients did not. So across all domains of the questionnaire, differences between the groups were not significant. Next, um, on the right, you can see a table, the change in Cardiff Wound Impact Schedule domain scores between start and end of the study, having adjusted for influence of baseline measurement taken at week 1. So each domain is transformed to a score of between 0 and 100. Differences in mean score changes between patients treated with NLFU plus SOC and those treated with SOC alone are shown. So next is the ulcer pain uh, and other characteristics. So NLFU plus SOC patients reported a mean reduction in pain score adjusted for the covariate of week 5 pain score, which had a significant influence points between week 5 and 13, while SOC patient scores reduced by negative 5.27. So last is the discussion. So the results of this study demonstrates that high quality wound care is instrumental in the outcome for patients with chronic venous leg ulcers, as demonstrated by the high withdrawal rate owing to the reduction in wound size during the run-in period and improvement in both primary and secondary outcomes in both arm of the study. There was a possible suggestion across several measures, including the reduction in size, pain, and complete healing, that NLFU plus SOC arms was superior to SOC arms alone. However, none of these differences were statistically significant. Therefore, it is not possible to conclude that NLFU therapy 3 times a week with standard of care accelerates healing in chronic venous leg ulcers compared with SOC alone. Although treatment with NLFU plus SOC reduced the mean wound area more than SOC alone. The difference was not significant using either a percentage or actual change in wound area. The differences in the primary outcome did not reach the predefined clinically significant effect of 20% between the two arms. So there was a little difference in patient reported measures using CWIS questionnaires between the groups, and the overall QOL showed a little improvement from the baseline in either arm. Patients in both groups of the study reported a reduction in pain, and although pain in the NLFU plus SOC arms reduced considerably more than standard of care arm, the difference was not statistically significant. Fewer adverse effects, including wound related adverse effects and infections, were recorded in the NLFU group. However, again, the difference was non-significant. So this is the first randomized trial on NLFU conducted in UK and has several strengths. So one, wound area measurements were performed by a single blinded assessor using a silhouette digital wound planimetry device. So a broad inclusion criteria were set. No patients withdrew following randomization. No patients were lost to follow up. And best available standard treatments were applied. Patient reported pain and QOL data were collected using a validated tool, which is the CWIS. Excellent patient compliance to the 3 times a week NLFU. So practitioner feedback was that NLFU treatment was well tolerated by patients. It did not add to the patient's pain or discomfort, and for some patients, there was a decrease in pain following the treatment, although the differences between the arms of the trial was not significant. NLFU was very easy to use within the clinical setting. This study suggests that while patients receiving NLFU plus SOC showed a substantial improvement in their wounds, most, if not all, of these effects was because of high quality SOC, which is the compression therapy with appropriate dressing. So applied by highly skilled practitioners in the context of clinical trials. So next is the limitations. So one, the difference in the treatment frequency between the groups, substantially longer trials required for the proportion of 100% healed wounds to be used as an outcome measure. Three, the open label nature of the study may also have introduced performance biases. And four, enrollment of homogeneous groups of patients in chronic wound healing studies is notoriously difficult. So last conclusion, these percentage changes corresponds to a small and non-significant difference in the actual wound reduction. This difference in the primary outcome did not reach the predefined clinically significant effect of 20%. The result of the study demonstrates that high quality wound care is instrumental for patients with VLU, as demonstrated with a high withdrawal rate owing to the reduction in wound size during the run-in period and improvement in both primary and secondary outcomes in both arms of the study. There was a possible suggestion across several measures, including reduction in wound size, pain, and complete healing, that NLFU plus SOC arms was superior to SOC arms alone. However, none of these differences were statistically significant. Therefore, it's not possible to conclude that NLFU therapy 3 times a week with SOC accelerates healing in chronic venous leg ulcers compared to SOC alone. That's all for our report. Thank you for listening.